Ma'am.
Please let us know when we go live.
Yes, ma'am.
We are live now. Dr. Meghna, who can start?
Yes, sir. Good evening, everybody. I, Dr. Meghna Argade from Pune Obstetric Gynec Society, welcome you all for the Cutting Edge webinar in association with Madurai and Tirunelveli Society. We generally conduct the Cutting Edge webinars every week with different societies on different topics. So today, the Cutting Edge webinar is in association with Madurai and Tirunelveli OBGYN Society. We can start our program with a prayer. Can we have prayer, please?
Mr. Nandkishore, can you play the prayer, please?
Yes.
शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः.
Thank you. I'll now request Dr. Aarti Nimkar ma'am for her presidential address.
Good afternoon, everybody. I welcome you all for this cutting edge webinar we are doing with the Madurai OBGYN Society and Tirunelveli OBGYN Society. Now, today's chief guest, I welcome you, Madam Revati, Madam, for this webinar. That is a unique program we have started since the 1 year. And it is, we are connecting with the different societies and including all the president secretaries and epoxy vice presidents and other renowned gynecologists for this webinars. And it is going on very on popularity. So we can connect the different doctors and different society and our candidate for the Foxy VP is starting the webinar and they can connect with the different society members. So it is a little bit help to get the nominations and votes for that post. So welcome, ma'am. And our chief guest is the Kalpana madam, is a Foxy Infertility Committee chairperson. And our Dr. Vaishali is going to speak on the tips and tricks for the safety in the laparoscopy. And for that, chairpersons are the Dr. Gayatri and Dr. Vaijanti Patwardhan. Dr. Vaijanti from the Pune and Dr. Gayatri from the Madurai. She is the president of the Madurai. Yeah. And some session will be on the hysteroscopic management of the return products of the conception. This is a very common problem of the MTP, and we are going to discuss on this problem, how to do with the hysteroscopic. And the speaker is Dr. Sapna, General Secretary of the Madurai Vijay Society, and chairpersons are the Monica and Dr. Gayatri. Welcome you all, and I think hello.
Hello. Yes, ma'am.
Yeah, you can take further this our MOC.
Yes, thank you, ma'am. Now I request Dr. Vaishali Sawan ma'am for a few words.
Thank you, Meghna. I just want to express my deepest gratitude to all the esteemed faculty who are present. Revati ma'am, who is the chief guest today. Madam, your presence adds value to the webinar. And thank you for immediately saying yes. And it's indeed an honor and Tirunelveli Valley Society to combine two big societies together and to be on the same platform. Thank you, Dr. Kalpana, for agreeing to be our guest of honor and for gracing this webinar with your presence. And Dr. Gayatri, ma'am, you immediately said yes that, and we went ahead and planned the webinar with Dr. Padma, with whom we've been coordinating, and Dr. Madhuwala, madam. For Tirunelveli also, you immediately said yes, and then we had this opportunity to connect with you and your secretary, Dr. Gayatri. So we are here to listen to your valuable inputs, and we're truly blessed with your presence. Thank you very much.
Thank you, ma'am. I now request Dr. Amol Lunkad sir to introduce today's chief guest, Dr. Revati ma'am, and today's guest of honor, Dr. Kalpana ma'am.
So good evening, everyone. As the clinical secretary of Pune Obstetric Gynec Society, at the first, let me welcome you all eminent guests, faculties, and delegates. Welcome to this webinar. First of all, let me thank Madurai and Tirunelveli Society for associating with Pune Obs Gynae Society for this webinar. And it's my privilege to introduce our chief guest for the evening, Professor Dr. Revati Madam. She is the former Director IOG Chennai, Vice President Foxy South Zone 2016. She was the President of Tamil Nadu Obs Gynae Society 2023 and Founder Secretary and past President of Madurai Obs Gynae Society. Also the President of past President of and the Founder President of Madurai Menopause Society. She has to her credits various awards, Lifetime Achievement Award by IMA Madurai, and she has to her credits several publications and chapters in various esteemed publications. So welcome, madam.
Thank you.
Our guest of yeah, madam.
Thank you very much, Dr. Amol, for your nice words and also kind invite of Dr. Vaishali and the entire Pune Society. I'm indeed very glad to be a part of this, especially as the chief guest to this interesting webinar organized by Pune OG Society. Actually, my link with Pune is like that. My first paper presentation was in ASOG Pune 50 years ago when they conducted it. It was a very, very nice thing. That is the ASOG in which I presented my first paper. Okay, so it was very nice at that time. And again, after this webinar for the past 4 years, we all have become much, much closer. And especially when you organize such webinars, connecting the societies right across the country, north to south, east to west, now it becomes much easier, and also it brings the experts to limelight. Say, for example, even this Dr. Padma is a pioneer in hysteroscopic surgery, Vaishali in endoscopic surgery. And through these webinars connecting the societies, we come to know about each other, and we also learn so many things from the experts. And the expertise is really made useful for not only the participants, but also all the patients also. Okay. So I'm indeed very happy that Pune is taking efforts to organize such interconnecting webinars with the societies. And I wish this conference webinar a grand success. Thank you very much.
Thank you, ma'am. Thank you for your kind.
Thank you for your blessings and your kind words. Thank you very much, ma'am. And
Thank you,
thank you
Vaishali.
for your very, very valuable presence.
Thank you, Vaishali.
To Madurai, ma'am, I will definitely come and meet you. I'm planning a visit there, CME.
Welcome. Thank you. Thank you.
So our guest of honor for today is Dr. B. Kalpana, and it's a privilege to have her here. She was the past chairperson of Foxy Infertility Committee. She is a gynecologist and fertility consultant at Guru Hospital. She is the course director for postdoctoral fellowship in endogynecology affiliated to MGR Medical University, co-chairperson of Infertility Committee of Tamil Nadu Obs Gynae Society, vice president of Madurai Obs Gynae Society, and we know her very well. She has been organizing various webinars for regarding infertility through Foxy and ISA, and she has published 15 papers in national international journal. She has various awards to her credit. Glad to have you, madam, here, and welcome to this webinar, and we seek your blessings here.
Thank you, Dr. Amal, for your kind introduction. It's really, it's my honor to be a part of this wonderful webinar organized by Pune Uji Society with its president, Dr. Aarti Nimkar, Secretary Dr. Meenakshi Deshpande, past president Dr. Meenu, and main person behind this webinar is Dr. Vaishali Chavan, past chairperson of Perinatology Committee, and Dr. Amal. I have worked with him as EC member when Kundan was Infertility Committee chair. Actually, with Pune, I have lots of respect and regards towards Pune Uji Society, not only because the Foxy president is from Pune, so Sunita Tandlewalker ma'am is from Pune, and also past Infertility Committee chairperson Kundan Engel sir was from Pune. And during my elections, Dr. Meenu and Dr. Vaishali were the president and secretary of Pune Uji Society. So I have lots of respect and regards to Pune office bearers and past office bearers. And also coming to the topic, laparoscopy, as far as gynecologists are concerned, we have been very comfortable with laparoscopy rather than open surgery, probably because of the posture magnification and recent advances. So we have interesting topics. All our friends are going to share their expert views and experience, and I should also thank Yambozis who had been calling us very frequently and reminding us about this webinar, and it will be really informative for the delegates, and my best wishes for the great success. Thank you so much.
Thank you very much, ma'am.
Thank you very much for your kind words. Yes, we do go back a long way, and you have a connect with Pune, and Pune has also always been supporting you, and we love to hear you talk. You're a great academician, and we enjoy your talks and your scientific deliberations. So thank you for being with us today and giving us your wishes and guidance. Thank you very much.
Thank you, ma'am. We will start with the first session. The speaker is Dr. Vaishali Chavan ma'am, and she will talk on tips and tricks for safety in laparoscopy. The chairperson for this session are Dr. M. Gayatri ma'am and Dr. Vaijayanti Patwardhan. May I request Dr. Amol Lunkad sir to introduce Gayatri ma'am and Vaijayanti Patwardhan ma'am.
Meghna, you go ahead.
Gayatri ma'am.
Can you show the CV, please, Mr. Nandkishore?
Yeah, she's Dr. Gayatri ma'am. She is HOD department and Government Rajaji Hospital, Madurai, President MOGS, UG PG teacher for the past 18 years, and recipients of Best Doctor Award twice from District Collector. And her field of interest is high risk obstetrics and endogynecology. I welcome you, ma'am.
Okay.
Just. And Dr. Vaijayanti Patwardhan ma'am, she is senior gynecologist, public health researcher, marriage and relationship counselor. Currently, she is Vice President IMA Maharashtra State, Treasurer of POGS, member of MTP Committee of Pune District and Pune Corporation, earlier member of PNDT Advisory Committee, recipient of many medical, social, media, and literary awards, state and national level trainer for maternal, child health, family planning. I welcome you, ma'am.
Thank, thank you, Dr. Meghna, and thank you, Vaishali, for inviting me, and wish you all the best. We are sure the participants are going to get a lot of good knowledge from you, from the vast experience which you carry. All the best.
May I request Dr. Gayatri ma'am to introduce Dr. Vaishali Sawan ma'am.
Thank you. Thank you, Pune OG Society, for collaborating with us and for the invite. And I am happy to introduce Dr. Vaishali, Clinical Director, Cloud9 Hospital, Director, Sanvi Clinic Women's Health Center, Vice President-elect, Pune OG Society, Chairperson, Perinatology Committee, FOXI, 2018 to 20. And she has publications in various books and has contributed to FOXI Focus and chapters in international publications. She has received the Inspiring Gynecologist Award by Times Group and Healthy Champion of FOXI by FOXI, Legends of Gynecology Award by FOXI 2024, Lokmat Award for Excellence in Medical Field, and many other awards. And it's a very practical topic. Laparoscopy, we are doing, it is the most common surgery that is being done in gynecology nowadays. And we are eager to hear about the tips and tricks to prevent injuries. Over to you, ma'am.
Thank you very much, ma'am, for your kind introduction. And thank you once again that you are here chairing my talk. It's truly an honor and a privilege for me. So thank you, Gayatri ma'am. Thank you, Vaijanti ma'am. So I'll just share my screen now. Is my screen visible now?
Yeah, it's
Yes. Yeah.
So without much delay, I would just like to start with the topic that is the intraoperative complications at laparoscopy. What are the tips and tricks for prevention, diagnosis, management? Basically, we are here at Pune, a holy city, just like Madurai and Tirunelveli. And we bring to you greetings from Pune. So first of all, it's important to remember for all the young gynecologists, all the young delegates who have logged in today, to remember that all the complications that happen are the fault of the surgeon, and there is no complication which cannot be preventable. So all complications can be preventable, and laparoscopy, you know, is a learning curve. And I started in 2010 with Professor Metler, and everybody goes through the learning curve with lots of complication, and that is how they learn. So over a period of time, with my experience in laparoscopy, I have realized that how to prevent complication is to take each surgery as your first. You know, as a junior resident, when you're about to do your first surgery, like a first tubal ligation or your first cesarean, you are so anxious. You go through the steps again and again in your mind, so that when you're operating, you want to be perfect. So treat every surgery with the same amount of attention and respect. Keep a cool mind, prepare the surroundings, plan the procedures, and the best of equipments are required. Many a time they say that, you know, as a laparoscopic surgeon becomes senior, then they start investing and buying better instruments. But actually, it should be the other way around. And the young laparoscopists should start with good instruments. And the entire team should be on the same page. So laparoscopy is one such thing that what you see on the screen, everybody who's present in the OT can also see what is going on the screen. So everybody has to be on the same page. Patient position for laparoscopy is so very important. If you give too much steep head low, sometimes the patient comes down. So it's important to put knee pad, shoulder pads. You may do a fantastic surgery, but if the patient has some knee injury, back injury, then that is not right. That's not forgivable. Height of the operating table is important, where the monitor is set up. Monitor should be just below the surgeon's eyes. We, as women laparoscopic surgeons, sometimes we just pull on like whatever is available, we just go ahead. But that adds to the stress, adds to the shoulder pain, adds to, you know, that correct positioning, especially of the monitor below the eye, is very important. Triangulation of the ports, This improves the ergonomics, and patient selection is very important, giving adequate antibiotics, prophylaxis, and so on. And in some cases, you may not go ahead with laparoscopy. Patient selection for very high risk, very complicated patient, you can always refuse. Knowledge of anatomy, tissue identification, I think these are principles for all surgeries, whether it's open or whether it's laparoscopic or whether it's vaginal surgery. Yes, with laparoscopy, there's a relative lack of depth perception, but over a period of time, you can actually identify the tissue and you can recognize even without the depth perception. And most important thing is call for help whenever you are stuck somewhere. Keep your ego aside and immediately call for help, call for seniors. So the major complications that occur are during various steps of the surgery. Either it could be during the primary step of insertion of trocar, it could be intraoperative technique, it could be early post-op, late post-op, and so on. Associated anesthetic complication, cardiac events, infection, all these may happen. As laparoscopists, they say the biggest predator for the bladder are gynecologists. So as gynecologists, because of the close proximity of the bladder to the uterus, there is risk of bladder injury, the ureter, the intestine. These are some of the organs which surround and which are at high risk of injury when we do laparoscopic surgery. Now, talking about entry techniques. Entry techniques is the place when you're putting in the entry, maximum injuries occur at entry technique and when you put the primary trocar. Many entry techniques are there, closed, open, and other techniques like optical trocars, radially expanding trocars, and all. The varies needed. And every surgeon should be proficient with at least one or more techniques. Suppose you put in a varies and you are unable to create a pneumo, then you should be well versed with the open technique and vice versa. So these are the few videos which I'm going to show. All these complications are not mine. They are also from my colleagues and complications which I have gathered from my colleagues from the net. So this is identification of injury. You can see this is a varies needle and it has gone through and through the bowel. So it's very common to have an injury like this, and many times it goes undetected. So when this happens, it is important to close the defect there and then. Any injury which is detected intraoperatively and managed immediately has a very good outcome for the patient, and the patient immediately recovers. So what is that checklist? How can we prevent this kind of injury? The basic checklist is this, that check the spring mechanism. Patient should be flat. Immediately head loss should not be given. Skin incision should be adequate to put through the needle. Lift the abdomen up. When you lift the abdomen up, it lifts it away from the vessels. Not necessary that it's going to lift it away from the ball, but it lifts it away from the vessels. And the angle depends on the BMI of the patient. And once you put in the varies, you can actually hear the audible clicks, rectus sheath and the peritoneum. And the various safety tests which are there, like aspiration test, hanging drop, hissing test, and so on. And it's important to know that once you put in the varies, and if you have a little bit of doubt also, you should not wiggle the varies side to side. One simple injury can expand, and cause a bigger rent in the bowel. So do not wiggle. So these are like simple tips which can are helpful in preventing complication. And modification of the insertion point. Yesterday itself, I used this point because the patient's abdomen was scarred. She had undergone a hernia repair with a mesh, or lap hole, an open laparotomy for ovarian cystectomy. So she had 3 prior surgeries. And that is the reason, because of that mesh and all, I did not want to put our usual. And I went up here at Palmer's Point. And Palmer's Point is that point where the adhesions are absolutely unlikely to happen. It is, you need to go through Palmer's Point. If you have little bit also risk that yes, there could be a ball adhesion inside. And the simple technique is to palpate the abdomen. If there are adhesions, your fingers can identify that this is not freely mobile. This area is not free. And a free area you can make out with when you palpate. And Palmer's point is a point when there is a previously scarred abdomen. So this is another injury when you introduce a primary trocar. Sometimes the trocar can, see in this particular video, you can see that the trocar has gone right through the bowel. And this kind of injury is very difficult to understand because your scope goes through this primary trocar. So only way this was picked up was because by the 5 mm telescope camera was attached, and this was identified that yes, primary trocar has gone through and through the bowel. Now, how do you understand that yes, your primary trocar is through the bowel? That first of all, there's reduction in the mobility, and you need to move 360 degrees once your primary trocar is in. Put the scope and move 360 degrees. At any point, if you feel there is an obstruction, then you know that yes, you have gone through some structure. And anterior abdominal wall, the only structure that is adherent is the falciparum ligament. There should not be anything adherent to the anterior abdominal wall. And if you feel there is an obstruction, the scope is not moving 360 degree easily, means you have injured bowel or you have gone through the structure. And when you introduce the primary trocar, minimum 15 mm of mercury should be the intra-abdominal pressure, and you should put it vertically and change the direction towards pelvis once you have crossed into the peritoneum, and less of force and more of rotation. That is what is required. And primary trocar injuries compromise of the maximum number of injuries. So this is the Hassan's technique, open technique. This is what I usually prefer. But in cases like yesterday's case, I used a for at the Palmer's point. In Hassan's technique, it is an open technique. It is under vision where you open all the layers of the abdomen, and they have shown that the risk of injury is less when you are entering under observation. So you can actually see all the layers, and then you enter through the primary trocar. So this is the Hassan's technique, and it is absolutely safe. Of course, there could be more of leakage of the gas, and you can just take additional stitch to prevent the leakage. The best technique is under visualization, where you can under vision insert the trocar, and you can see all the layers, peritoneum, fascia, and so on when you enter under vision. So this is under vision, that the trocar, optical trocar, what we call. So for a scarred abdomen, optical trocar is a blessing, and it should be used. So when you have gone through some injured, you can actually visualize with optical trocar. The risk of injury is not reduced, but you can pick up the injury there and there itself. You will know, since you are entering under vision, you will know that yes, you have entered through bowel. You can diagnose it there and then on the table and repair the whatever injury has happened. You can manage it there and then. So evidence for visual entry, they have said that maximum number of complications occur at visual entry. Sometimes you overshoot, you take a small skin incision and you try to push the trocar. And if you push it too much forcibly, it can go and injure and cause overshooting, as is in this particular stage, because of the force that was applied. It went and hit on the opposite side, and there was overshooting, and there was bleeding here because of the forcible introduction of the trocar. So overshooting force should not be done, and you have to respect the tissue and respect the procedure. So open laparoscopy also has its complication. The risk of vascular injury is definitely reduced, and it reduces the risk of unknown gastrointestinal GI injuries. Complications due to entry ports, where they have said that yes, the risk of infection may be a little bit more, and also depends on the hospital hygiene. So there are various methods to create pneumo, varies open laparoscopy, optical trocars, and so on. And when you insert a secondary trocar, we are always worried about the inferior epigastric injury artery. And inferior epigastric artery, when it starts bleeding, like it bleeds a lot, and it's important to tackle that bleeding there and there itself. And how to avoid inferior epigastric injury? Here is the case where it is just pouring and bleeding. And then finally, this had to be tried coagulation. With coagulation also, the bleeding did not stop. And finally, a suture had to be taken to stop the bleeding. But any bleeding hemorrhage, if there and then it is tackled, then the patient, not much harm is done for the patient. So it's important here, you can see the round ligament. It's important to trace the round ligament where you get the inguinal canal, and just medial to the inguinal canal is the inferior epigastric artery. So if you are in a doubt as to where the inferior epigastric artery is, this is the anatomical location. Also, trans-illumination is a method where you can trans-illuminate and look for the vessels before you put your secondary trocar. So for this kind of bleeding, inferior epigastric artery can really bleed. And if neglected, patient can even go in shock. So vascular injuries need to be tackled there and then on table. Otherwise, patient goes in shock, bleeds, you need to give transfusion and so on. So complication which occur could be due to surgical or due to internal organ injury. Like I said, gynecologist is the biggest predator for bladder. And this was a clear-cut bladder injury, previous cesarean, and while dissection, suddenly it was realized that yes, bladder has been injured. But if there is bladder injury, in fact, it's really difficult to injure a bladder. Bladder tissue is, after doing so many cesareans, we know how to identify bladder tissue. And if such a kind of bladder, this is the bladder injury. And if such a kind of bladder injury occurs, then you can suture it immediately. It's very easy to suture bladder. And you can use 2-0 or 3-0 Vicryl and suture it in 2 layers. And bladder is a forgiving organ. And if you put in a catheter for 7 to 10 days to rest the bladder, earlier they used to say that keep the Foley's catheter for 21 days and push in methylene blue, see if there's leakage or it is leak proof. But nowadays they say 7 to 10 days also catheter if you put, rest the bladder for 7 to 10 days and then you remove the catheter, patient does wonderfully. So bladder injury actually is very easy to repair, and the recovery is very fast in bladder injury, and not so in ureteric injury, where you do need a urologist to be there if there is a ureteric injury. But any injury that is detected intraoperatively and managed there and there gives wonderful results, the same way as if there has been no injury. So sometimes the bladder is adherent, like previous to cesarean, and you are expecting bladder injury. In such cases, the lateral window approach is important because the bladder is adherent centrally. When we do cesarean, the bladder goes and adheres centrally. So you go laterally and where there is no adhesions and create a lateral window, and from lateral, you go medially. Another technique I like is holding up the bladder by forceps. So when you hold the bladder up, it is out of your way. And then you do the dissection, and traction is very important. Wherever there are adhesions, traction in laparoscopy surgery plays a very important role. So diagnosis of bladder injury, there could be in the urosac, there could be a swollen bladder, entrapped CO2, or there could be hematuria. And many times the bladder injury occurs if there are severe adhesions or there's a large fibroid, myomectomy, or previous 2 or 3 cesarean, or DID infiltrating endometriosis, and so on. So bladder injury is something we encounter very frequently. The prevention is catheterization of bladder. Trocast should be put under vision. Dissection should be done very carefully. And you should be able to identify the bladder tissue from other tissues and prevent these kinds of injuries. So prevention of bladder is clear understanding of the anatomy and good dissection. Electrosurgical, you need to use limitedly approach the adherent bladder by creating a lateral window and dissect bladder adequately, almost 3 centimeters beyond the place where you're going to do the vaginotomy, or you're going to cut the vaginal vault. So these are the basic principles. For ureteric injuries, you need to be alert, especially if there's pelvic endometriosis, large uterus, pelvic adhesions, and so on. So for prevention of ureteric, this is something which we teach our students even while doing abdominal hysterectomy, that it's important to dissect the posterior peritoneum. When you dissect the posterior peritoneum on both sides, the ureter just falls and the risk of injury to the ureter is less. Another important point is when you take the uterine artery, then you need to stay medial to the uterine artery and not go laterally. So bladder injuries, if you feel, sometimes there could be thermal bladder injuries or thermal injuries for ureter. And these patients usually present 2 or 3 weeks later. And in such cases, you need to involve the urologist. This is a rectal nodule injury, again, in DIE patient, deep infiltrating endometriosis. And for such a kind of injury, you need to involve the surgeon. Medico-legally also it is right, and the expertise is also, as gynecologists, we are not that proficient in bowel suturing. So we need to involve surgeons and be safe for ourselves and our patients as well. This is a simple procedure where there has been small bowel injury, where these are the endometriotic cysts, and while dissection of the cyst, the bowel was opened, and this is the bowel injury. But since it was detected on table, it was sutured there and then, and patient had a very good outcome. So anything that is managed on table intraoperatively gives excellent results for the patient. If you do not diagnose the complication, then that is a negligence. Creating a complication is not a negligence, but not diagnosing the complication, not managing the complication is a negligence. This is another video which shows how the thermal injury has happened, and the bowel got injured. And since this is where it was, and since it was detected, it could be managed there and then. So bowel can be injured by direct trauma or by thermal trauma, bipolar, and so on. So uncontrolled bleeding, coming to the end, almost end of my presentation, uncontrolled bleeding obscures the vision. Any kind of thermal injury needs to be managed there and there, doing suction, localizing the bleeding point, and then controlling the bleeder is very important. So in any case, any vessel that is injured, it is very important to control the bleeding quickly. Pressure can be applied, but if there's a large venous injury, the more you handle it, the more it is going to bleed. First of all, so vascular injury, do not panic. Do suction, identify the bleeder, and then you tackle it. The management depends on where is the vessel, what is the type of vessel, and either you can coagulate, or you can put clips, or you can suture. And if it is uncontrollable, you can just open the patient and stop that bleeding, but it needs to be stopped. This is again uterine artery bleeding. As you know, uterine artery really bleeds. And this was a good clean case, but suddenly there was a bleeder which started bleeding, and this is the left uterine artery bleeding which has been bleeding, and it has completely obscured the vision. And after doing adequate suction, exposure, and then this bleeder was taken and it was controlled. So other complication could be pulmonary embolism. It's important to use stockings, pumps, and so on. So to conclude, I would like to say that complication can happen The more experienced the surgeon is, the lesser are the complications. And most complications are accidental. No surgeon goes out of the way to create complication. But diagnosing the complication and managing is important. Understanding the anatomy, the suturing, the principle of energies is very important. So, as Hippocrates said, primum non nocere. First of all, do no harm. So, thank you everyone for patient hearing. And I seek your blessings and support for the post of Vice President Foxy West Zone election year 2025. Thank you, everyone.
Thank you very much, Vaishali ma'am. May I request Dr. Gayatri ma'am and Dr. Vaijayanti ma'am for expert comments?
It was a wonderful talk and very practical points for the laparoscopic surgeon. And also like to add some few points. Basically, we have to ensure that the stomach is empty. Actually, we had a case of Viri's injury to the distended stomach. During anesthesia induction, they have inflated the stomach, and during the Viri's, it directly entered into the stomach actually. One of our colleague did that, and we recognized it and we sutured it. So we have to ensure that the bladder and stomach is always empty. Better to put a nasogastric tube at least, and the bladder should be empty.
Yes, ma'am, rightly said, and it's very easy to injure even with the Veris. So what you're saying is very true, ma'am. And to have an expert like you chairing the talk, truly privileged, ma'am.
Thank you.
Yeah. I would just add, Dr. Vaishali, it was a wonderful presentation, a very lucid talk with so many practical tips. Laparoscopy has definitely taken over the open surgeries. Ours was the time of open surgeries, but nowadays, it's made the life so simple for the patient, especially, and of course for the surgeon also. And then, of course, the points which you mentioned, which are really the practical tips for any new person, and there's no need to get scared, but always be vigilant about the possibility of some complication. And as very rightly told by you, encountering a complication is not a crime or will never be considered as a mistake of the person, but not realizing in time is what is definitely not acceptable, and that's the reason why one has to follow all the safety tips which are given by you. So thank you for the presentation and all the contents of your talk, and wish you all the best for the election. We on behalf of Pune OBGYN Society and of course Madurai Society, 100%, 105% with you. All the best. Be blessed.
All the best, Vaishali madam.
Thank you,
And
Gayatri.
also we have to we concentrate more on the surgery. We have to concentrate also on the positioning of the patient actually. And you rightly pointed out the role of those shoulder pads and everything, positioning. And post-operatively, it will be a major problem for complaint of the patient. So we should concentrate on the positioning of the patient to prevent nerve injuries and adequate padding of the knee and shoulders, etc.
Right, ma'am. So rightly said. And as women gynecologists, many a time, they are already set, all the systems are set, and we just go and operate in the same.
Yeah.
We can change it to our level and make ourselves more comfortable. Those are challenges we face as women surgeons. Right. Thank you so much, ma'am. Kalpana,
you.
madam, you want to add anything? Kalpana, ma'am? I think she's on the mute. So we can proceed further.
We'll move on to session 2. The speaker is Dr. S. Padma ma'am. She will be talking on hysteroscopic management of retained products of conception. The chairpersons for this session are Dr. Madhubala and Dr. Gayatri. Dr. Madhubala is a senior consultant obstetrician and gynecologist, President Tirunelveli OBGYN Society. She has received gold medals during her MBBS, MD, and DNB career. She is professor and course director at Institute of Lakshmi Madhavan Hospital Private Limited, Tirunelveli. And the key areas of expertise are high risk obstetrics, laparoscopic and hysteroscopic surgeries, infertility and IVF treatment, and medical education and training. Welcome, ma'am. Dr. S. Gayatri, ma'am. She is consultant obstetrician, SMS Hospital, medical director, Hari Fertility Center, secretary, Tirunelveli, Foxy. The affiliation, she is member of Foxy, TNOGS, IFS, ISAR, IMA. And the special interests are high-risk obstetrics, infertility, hysteroscopy, preventive obstetrics, and adolescent health. Welcome, ma'am. Now, may I request Dr. Gayatri, ma'am, to introduce Padma, ma'am.
Hello, thank you for having me here. It's an honor to be a part of this group. And I'm very happy to introduce Dr. Padma. She is, actually, we had her lecture last month with us. So she's the senior consultant and HOD in Meenakshi Mission. And she's the present secretary of Madurai Obs and Gyne Society. And she's a very renowned laparoscopic, hysteroscopic, and robotic surgeon in our area. And she's also a very active member in the oncology group, and she heads our TNFOG oncology team. So we're all eagerly waiting, Padma ma'am, for your talk. And it's an honor to introduce you, ma'am. Ma'am, Padma ma'am.
Hello, good evening.
Hi.
Everyone. Hi. It's so nice.
Yeah, again to see you. It's nice to see you again, ma'am.
Yeah, Gayatri. Thank you for the introduction.
And
yeah. You were saying something, Gayatri?
no, ma'am, we're just waiting for your talk.
Yeah, sure. At the
Thank
outset,
you.
I'd like to thank the Pune Society, the office bearers, and Vaishali for inviting me here. And Meghna has done a good job of, coordinating and convening this. And my regards to today's chief guest, Revati Madam, and guest of honor, Kalpana. And that was a very beautiful talk from Vaishali. And I was just telling my PGs, just please listen to it. These are all things which we will, you may face in the future. We have also had our set of complications and we have managed it. If somebody says they have never had any complication, it means that they have not done adequate surgeries. That's what I would like to say. Now coming to today's topic given to me, hysteroscopic management of retained products of conception. Retained products of conception is a very common clinical problem. And when we say RPOC, we mean residual placental or fetal tissue, either following termination, miscarriage, or after delivery. And RPOC is not just only after miscarriages or MTPs. And nearly 1% of even full-term pregnancies delivered by either by vaginal C-section can go in for a retained products. And the most important risk factor for a retained product is an adherent placenta. And any person who has had a manual removal of placenta, or if there was any postpartum hemorrhage, or when there was any previous history of RPOC, or previous pregnancy, she had a difficult placental removal, and this can even happen during C-section. So when this sort of history is there, it is important that we closely look for retained products even after term delivery, and check it out by an ultrasound in the immediate postpartum period. But it's very commonly 99% of the times it follows a miscarriage. And the most common clinical signs we all know is an abnormal bleed associated with or without pain abdomen and fever. But we all agree that the long-term complications, especially in a woman who is planning future pregnancies, could be endometritis and intrauterine adhesions. And this all can lead to secondary infertility. So when they come for an MTP, and then commonly now we give medical methods of termination, and we call back the patient 10-15 days later for a repeat ultrasound. And in the repeat ultrasound, if we see an endometrial thickness which is less than 10 mm, we can be highly assured that there is no products, literally no products of conception. But whenever the thickness is more than that, or when there is an irregularity in the endometrium, or when there is a heterogeneous intracavitary hyperechoic focal mass lesion, if there is any fluid inside the endometrial cavity. Sometimes the retained bones, they can appear as calcified lesions in the endometrial cavity. Apart from that, color Doppler also helps in picking up the abnormal products. Any products, retained products of conception are likely to be highly vascular. The presence of vascularity within the endometrial echogenic material supports the diagnosis. But then at the same time, I would like to say that the retained products of conception need not always be vascular. They can be avascular also. And the other thing is sometimes we do beta HCG and we say beta HCG is negative and then there is less likely to be retained products. It's not so. Beta HCG is elevated only when the chorionic villi is active and forming beta HCG. And suppose somebody patient is having a chronic retained products and she's having a placental polyp or something like that, then once again the beta HCG is likely to be negative. So it doesn't rule out retained products. It is only imaging and a high amount of suspicion which helps in clinching the diagnosis. The other important differential diagnosis is AV malformation. Nowadays, with better imaging, we see many patients who are coming to us with AV malformation. At least once in, at least we see 3-4 patients every week coming, getting referred to us because it's a referral center saying that there is AV malformation and for further management. When we say an AV malformation, it means a multiple hypoechoic myometrial spaces with systolic and diastolic multidirectional turbulent flow. And when it comes to retained products, when it is associated with retained products, we can see this vascularity extending into the endometrial cavity also under the products. Whereas a pure AVM, it can be located exclusively only in the myometrium. This is how it looks when there is a AVM, and you can see the multi-directional high velocity flows. And when there is an associated product inside the cavity, it extends into the cavity also. And the treatment typically for an AV malformation, initially we do a higher imaging, either a CT or MR angiogram to see which vessel is the supplying vessel and other things. And if possible, either if we have an interventional radiologist, then we do a uterine artery embolization. Otherwise, we can approach it laparoscopically, especially when the patient is bleeding, and then like get the internal iliac or the uterine artery at origin and control the bleed. So now coming to this RPOC, we have this beautiful Gutenberg classification, which clearly says to what extent these products are vascularized. In the picture, you say A, that is type 0. Gutenberg, as per the Gutenberg classification, and it just says a hyperechogenic mass with no vascularity. And in B is type 1, which is minimal. C is type 2, there is increased vascularity in the products only. And in D, there is associated myometrial vascularity also. This is very, very important for practical purposes, because when somebody is dealing with retained products, and if it is only A and B, then it is okay, we can easily get off. But then when it is something vascularity is high, as in C and D, then we need to make some efforts to control the bleed, either pre-op or intra-op, so that we don't end up having massive bleeds and then having a patient with shock on our operating table. So this is what is important. It's highly beneficial for our surgical planning. And if we have, if we are in a, what do you say, we don't have facilities for blood transfusion or support systems, then in that case, whenever the vascularity is very high, as in C and D, it is better to refer the patient to a higher center where this kind of problems can be tackled with. So it helps in choosing the safest procedure and environment to safely perform the procedure. This is a standard algorithm. Any patient with RPOC, when they are in an acute state and the bleeding, then we straight away take up for DNC. We can even be ultrasound guided also to ensure that the cavity is empty. And sometimes if it is bleeding is associated is very heavy, and maybe in a patient with GTN who is bleeding, we may have to resort to a hysterectomy. But most of the times, a patient with a chronic retained products is hemodynamically stable, and in these patients, either we can give a expectant management, medical or surgical, and the surgical part can be either a blind DNC or a hysteroscopy. But the problem with these blind procedures is we are not sure whether the cavity is once again completely evacuated, and because of that, there is a risk of re-evacuations, and that leads to intrauterine adhesions, and a small percentage, when we keep on doing it, it can lead to uterine perforation also. So because of this, now it has been clearly said that a guided hysteroscopic guided evacuation is the gold standard, and this is a literature which has been published. It's a review article published in 2021. And which clearly says with the hysteroscopic evacuation is associated with a much better clearance. In a plain simple DNC, the chance of incomplete evacuation can be as high as 30%, whereas with hysteroscopic guidance, it's less than 1. And because it prevents evacuation, as I said earlier, the risk of intrauterine adhesions is much less with a hysteroscopic resection. And because of that, the pregnancy rates also much better. And this is another large study and review article done by Virginia Forrest, and who published recently in 2021, and they have also come out with similar findings. So now when we, as I mentioned earlier, we know about the Gutenberg classification. But then when you extrapolate it to hysteroscopy, there is a very good correlation. And see in the first picture, in the upper row, what you see is something which corresponds to the Gutenberg's type 0. The products are adherent, they are all fibrosed, there is no vascularity at all. And the upper right-hand one is type 1, there is minimal vascularity. You can see the, chorionic villi-like appearance, shaggy appearance, but the vascularity is less, and so it's a little pale. The same thing when you look down the lower row, the first picture, because there's a little more vascularity, the same villi is little more pinker and more vascular. But in the last picture, the lowermost, when there is marked, vascularity like an AV malformation, you can even see the bulging vessels on the surface of the products. So the hysteroscopic management of RPOC is dependent on how large the mass is and how vascular the products are. So based on that, we have different techniques of removing the hysteroscopically the products of conception. One can either use a mechanical method like scissor grasper, like any other polyp, or sometimes we may have to go use a resectoscope. And the resectoscope can be used as a cold loop without activating the diathermy at all, or we can use a diathermy either monopolar or bipolar. And in recent days, we have this mechanical hysteroscopic tissue retrieval devices, and which are very good. I'll just come to it. And in our hospital, we have this one by TrueClear system. And each one has got its own advantage and disadvantage. As I said, resectoscope can be used both as a cold one or as in the activated way. And this is the mechanical hysteroscopic tissue removal. There are two kinds of blades there. One is the soft tissue morcellator, and the other one is for the firmer and harder tissues. The morcellator, it just shreds the polyp or the products and it sucks it out at the same time, so that there is no accumulation of this tissue material inside the cavity and coming in the way of further removal. The tissue, the cavity is always clear throughout the procedure. But the problem is, if there is any bleed, then we will have to remove it and then use a resectoscope or a ball cautery to catch the bleed. That's the only problem there. And because right now we don't have the smaller systems, mini loops in India, we may have to do more dilatation compared to a resectoscope. In the resectoscope, the advantage is, disadvantages are, because we're using electricity, there is a possibility of damage to the overlying or neighboring endometrium. And the other important thing is, we will have to remove a scope and then repeatedly do the tissue extraction. So coming to a few case examples, this is a patient with whom we had managed a type 0 to 1 RPOC. She's a 44-year-old lady who had an IVF elsewhere, and she aborted. And she came to us after 2 months with irregular bleed on and off. And ultrasound showed suspicious retained products. And we went in, this is the picture, while the rest of the cavity is quite fine. You could see both the ostia there. You can see the products which are adherent to the posterior wall of the uterus at the fundus. So here I'm using a receptoscope as a cold loop. It's like a our regular DNC curettage, but the only thing is we are seeing it with precision, seeing where the products are attached to, and gently teasing it out with our receptoscope. And when you see here, we are you can appreciate that we are not touched the rest of the endometrial cavity at all. We are just teasing out the products from the place where it is attached to, and then slowly and gently we are able to remove it completely outside without damaging the endometrium cavity. And then a 44-year-old woman who has few embryos left behind frozen, she can always easily go next time and then have her embryo implanted without the fear of any Asherman's or intrauterine adhesions, because this evacuation has been done under precision. This is yet another patient, a similar history, and what we are using here is you can see me using the tissue retrieval system. So we just have to place it over the retained products, and once you activate the foot pedal, you can see that it slowly modulates or shreds the tissues, and then it keeps sucking it. So at the end of the procedure, once again, it's very precise. We are just catching the tissue where it is adherent. We are not touching the rest of the endometrial cavity at all, not disturbing it. And at the end of the procedure, you can see it has been completely removed. We know that there is no more further products inside the cavity, and we have not damaged any part of the endometrium at all. This is very, very important. Now coming to another patient with type 2, this one RPOC, we have used a combined method. Here the tissues were a little more fibrotic. We have gone in with our hysteroscope and the tissue retrieval system. We are first, and I'm using a dense tissue mode, so that because it's more fibrotic. So this denser tissue mode is the one which is usually used for fibroid polyps. And here, because it's more fibrotic, chronic products, we have just used that. And the vascularity is little more. So once the tissue has been removed, I'm just going with the receptoscope for removing the little bit of tissues which are stuck at the base. And you can see there's a little bleeding there. Then as and when I am doing it up, it is getting cauterized and the vessels are blocked. And so that is the end of it. So we are sure. And this patient, we called her back 2 months later. And what you can see is, because I've used little amount of diathermy, even that little amount has caused some amount of adhesions in the endometrial cavity. And then now here I'm now going only with the scissors. I'm not using any diathermy, so that the endometrium is not damaged anymore. And this particular patient, she gives history of repeated abortions. And when we evaluated, initially I didn't appreciate it. But then this time when I went in for the adhesolysis, I found that she was having a little bit of a T-shaped cavity. So we are correcting that also. So on the opposite side also, when you see, the scope was at the level of the internal os, we couldn't see the left side osteo also, and so making a linear metroplasty on the lateral wall of the uterus. So that is the advantage. So when you do use a hysteroscopy, we can do the correction of the other problems, associated problems, let it be the septum, or if there is any submucous fibroid, that also can be tackled with. This is a very interesting case. She is a primigravida. She came to us with post-abortal bleeding of 1 month duration. She had an evacuation outside for profuse bleed, and when she outside they done an ultrasound, they found her to have an RPOC with increased vascularity. An MRI also was done in July, and that showed a very large mass retained products, almost 7 centimeters in size, and the beta HCG also was elevated. So they went in and then did a DNC, and the HPV revealed chorionic villi. But in spite of that, her symptoms persisted, and the repeat DNC was done 10 days later. And this time, the histopathology did not reveal any chorionic villi. But the beta HCG was persistently high, and suspecting a GTN, she was referred to us. And in our center, when we did an MRI, we found that she was having a retained tissue mass at the fundus, almost around 3.5 to 4 centimeters in size, with marked thinning of the myometrium also. and our radiologist had reported that it could be a molar GTN, and the beta HCG also was elevated. Initially outside it was 16, but then when we repeated in our center, is almost 64. And this patient, she was bleeding when she was on admission, and her hemoglobin was just 4 grams. And considering the vascularity and other things, because she was actively bleeding, we went and then did the bilateral uterine artery embolization. And because the beta HCG levels were increasing, the patient was discussed in the tumor board, and she was given a single dose methotrexate 50 milligram IM and alternate days for 4 doses, following which there was a fall in the beta HCG. But somehow her symptoms persisted, though it was not a heavy bleed. She kept on having minimal little bleed persistently, and that was when we thought we'll just go ahead, put in a hysteroscope to see, and then see whether we can evacuate it. And we did a hysteroscopic evacuation, and the histopathology this time was a partial vesicular mole. Following the evacuation with the hysteroscopy, her and the beta HCG level dropped significantly from 64. 15 days later, it came down to 600. So this is the patient's picture. Can you see the huge distended vessels on the surface of the retained products? And we are just went in directly with the resectoscope only. I'm using a bipolar resectoscope. It's aligned as the distension media. We are not using any monopolar. And then under vision, gradually we removed all the products of conception. And I took out the scope, waited for 2-3 minutes, so that if there is anything inside the myometrium, that will get with the contraction, where the anesthetist had given this one, vasopressin. I had given vasopressin to reduce the bleed, and he had given, say, oxytocin 10 milligram IM, so that the whatever products is within the myometrium also just comes in back into the endometrial cavity, and then we have ensured that the products have been completely removed. And then as and when there was bleeding, you can see me cauterizing it, the bleeders there. And we put in a Foley's catheter for better hemostasis and came out. And this patient, we continued another 3 doses, another 2 doses of methotrexate after the normalization of the values, as how you do for any GTN. And this patient still under follow-up, and we have asked her not to conceive for the next 6 months, so that we can be sure that if there is any recurrence of the disease, we can catch it. There's another interesting case. This patient had a cesarean scar ectopic pregnancy, which was treated at Singapore with KCL injection into the sac and methotrexate. But she had a persistent bleeding on and off, and then at that point of time, she came to India and then was registered in our OPD. And on ultrasound, we found that there was an irregular gestation sac in the scar site of approximately 3 centimeters, and the MRI also confirmed the findings. And this was how it looked like, because she had persistent symptoms and it was in the niche. So we thought we'll just put in a hysteroscope and then see whether they remove the products. And as we go in, I'm using the hysteroscope only as a cold loop. You can see the products are very pale. And because of the the methotrexate injection, and they had given KCL injection, so the fetus is dead. That is not a live tissue, but still it is adherent, and then giving the patient trouble. And you can see, as I'm using it as a cold loop without using energy initially, so that it just gets completely removed. And the base, a little bit of tissue at the base, we are using a diathermy at the end. We have to be very careful when managing this scar ectopics hysteroscopically, because if the niche is deep, there is a risk of injury to the overlying bladder and other tissues. So you can see it. I'm just not even passing the loop deep. It's very, very superficial cuts, removing only the adherent products. And this patient, after this, she had a complete, that particular bleeding had stopped, and beta HCG also subsequently was low. And we called back all these patients for a repeat check. And this patient, when she came to us 6 months later, she again had a persistent post-menstrual spotting for a longer time, which is typical of a niche. Patients with post-cesarean niche, they always complain that they have AUB, and then usually it is in the form of a post-menstrual niche, because this menstrual blood collects in the niche, and then they keep spotting a little later on. And this picture when we went in. It was a deep niche there. And this patient, she wasn't interested in further pregnancies. And that is when we thought we will do a hysteroscopic repair of the niche itself. And when you do a hysteroscopic repair, when you plan one, we need to be sure that the overlying myometrium, residual myometrial thickness over the niche is at least more than 3 millimeters. Anything less than that will cause injury to the overlying bladder. So here I am just resecting the upper border of the niche, and following that we are just coming and then resecting the lower border. So it is just cut only in the anterior and lateral, and the posterior wall is left intact. This is very important because the posterior wall also is injured, then there can be possibility of adhesions, and the patient can go in for Asherman's and occlusion of the internal loss of the of the uterus. And with this, we did a sterilization also for the patient. That's very important. When you do a hysteroscopic repair, the scar is thin. That's a wider scar. It is not thinned out. It becomes a wider gap in the myometrium. And I don't know how much safe the future pregnancies are. And this is another patient. She had a medical abortion elsewhere, and because when she started bleeding, the practitioner there tried to evacuate the products vaginally. But she ended up with having a profuse bleeding on the table. She was resuscitated and sent to us. And when she came here, so this was the picture when we went in. You can see a lot of adhesions. The uterus is, we went in through a laparoscope. We are just releasing all these adhesions. And when you see the scar has opened up, and the can see the scar ectopic tissue protruding through the cesarean scar. The contents were evacuated, and we just went ahead and then did a scar revising, and then was proper suturing in 2 layers. I've almost come to the end of it. So the post-op management for these patients is, especially when there is used diathermy and other things, to prevent intrauterine adhesions, one can give estrogen, and along with a proper antibiotic treatment. And it's always important to follow up with a follow-up hysteroscopy 6 to 8 weeks later, so that the early formed adhesions which are flimsy can be easily separated. And now there are some authors who manage regularly their missed abortions, that is missed abortions with the hysteroscope, and there are a humpty number of papers in the literature. And the other important thing is something we called hysteroembryoscopy, and in that patients who have repeated abortions, and we want to subject the products for a genetic evaluation, we can go in through a hysteroscope, remove only the products without contamination of the maternal residual tissue, and then send it for evaluation. So coming to the summary, the advantage of hysteroscopic RPOC is the removal of the tissues can be done even from hard to reach areas like the scar niche and the uterine cornu. And at the same time, the associated problems can be corrected, like septum congenital, or when the patient has a submucous fibroid, as I said earlier. And the other advantage is removing the fetal tissue for genetic testing and to avoid a misdiagnosis of AV malformation. Once again, thank you for the patient hearing and the opportunity. Thank you.
Thank you very much,
Thank you,
ma'am.
Dr.
I now
Padma,
request.
this was a wonderful presentation. Yeah, it was a wonderful presentation. And as you rightly said, hysteroscopy should be the cornerstone in the management of retained products of conception, rather than going for a blind curettage. Most of them would probably end up in Asherman's also.
Yeah.
So as a bonus, we also could see your isthmosil correction. And and one question is that you've been giving this GTN patient alternate days of methotrexate 50 mg.
Yeah.
And folinic acid was also given for these patients, or how did you?
Yeah, with folinic acid rescue only. So that part
every 48 hours.
Yeah, it's that 8 days regime. Alternate days we give methotrexate and folinic acid.
Ma'am, the vasopressin injection, ma'am.
Yeah.
So do you routinely give for all RPOC removal, and how do you give how much?
Not always. As I said, type 2 and 3, where we expect much bleeding, there is highly vascular products. So at patients, we give a vasopressin injection, just like how we give a paracervical block, no? At 2 and 10 o'clock positions, we inject it. And it gives, the tissue gets blanched well, and then they don't bleed much.
Excellent talk, Padma ma'am. Really impressed with all the videos you have shown and the quality of the videos, the visualization, your surgical expertise. A treat, a visual treat for us, and I'm sure for all the delegates, all the attendees who have joined. Really enjoyed your talk, and hats off to your great expertise, ma'am.
Thank you, Vaishali. Thanks for the kind words. And your talk also was awesome. It was really awesome.
Very, very nice talk, Madam Padma. It is very eye-opening and not the blind ANC for the every written product, but it is the histoscopic guided for the grade 3 and grade 4 is very important and very essential to see the nature of the product and how adherent they are to the uterine cavity. Very nice.
Thank you,
And
ma'am.
one thing you highlighted during isthmus seal correction, which everybody should notice, don't go in for the posterior correction also, but because it will go cause stenosis and Asherman's and all those things. Anterior lateral walls can become posterior wall. As you said, it will go for cervical stenosis and Asherman.
Yeah.
That was one good point.
Yeah.
Take home message.
Yeah.
Exactly. Padma, your talk was excellent because they're all with the nice case presentations. Made it very lively.
Yeah, thank you, ma'am. Thank you. Otherwise,
Thank you.
it's boring. Yeah, thank you.
We did not want it to end. We were hoping you'll show more and more cases.
Actually, I had a few more cases, and I have to thank my postgraduates. They do such beautiful editing for me. And we had a couple of cases where the product was sitting on the submucous fibroid also. For a lack of time, I didn't put all that.
Really good. Really.
Thank you.
Nice, Vaishali. Your talk was also excellent.
Thank you, ma'am.
Vaishali.
Yeah. And I know
Padma,
Madhubala
I became your fan.
Yeah, thank you. Thank
We
you.
all have.
Yeah. Madhubala also has a TrueClear system, if I know well. Is it correct,
Yes,
Madhubala?
yes. Good in billing. It is such a wonderful tool so that it doesn't damage the endometrium at all.
Yeah.
No, the endometrium is totally secure, and you have your whatever effect you have, the result it is so good with TrueClear.
Yeah, it's true. But the
And
only
this
thing is a little
topic was
expensive.
taught first time in the webinar. This cutting edge webinar, this topic is taken first time.
Oh,
Yeah.
yeah. Thank you.
Thank you. Nice.
Thank you. Thank you once again, Pune Society.
Thank you all for joining us for the cutting edge webinar.
Yeah.
We wish Dr. Vaishali Chavan ma'am all the best for the election for the post of Vice President, Foxy West Zone. And we solicit your support for Dr. Vaishali Chavan
Everybody
ma'am.
must remember
I
Dr.
forgot.
Vaishali
I forgot. Vaishali, all the best. Wish you success in the election.
Thank you, ma'am. Thank you for your blessings, ma'am. Thank you.
Vaishali, all
Thank
the
you, ma'am.
best.
Hi, and it was a wonderful seminar and cutting edge. So thank you, Vaishali. Thank you, all the office bearers of Madurai Society also. And thank you, friends. I'll exit now for the
Reddy
next
ma'am
meeting.
was there, Kalpana ma'am joined, Dr. Padma, Dr. Gayatri, Dr. Madhubala, Dr. Gayatri, all of you came and graced the webinar. Like we, Pune Gynec Society, we truly, truly are very thankful to you. And thank you to Dr. Meghna, our young here with in this,
Thank you, ma'am.
the BSV who are with us today, our academic partners.
Thank you.
Thank you. Thank you for
Thank you,
coming.
Vaishali.
Thank you.
Madam, thank you.